Okay, I think we're going to get started, everybody. I'd like to welcome everyone to the kickoff of our 2024 webinar series. My name is Amy Leitman. I'm the president of NTM Info and Research, and I will be the moderator for today's session. We're very excited to welcome today several speakers from the Yale University School of Medicine. Today's session is an update on NTM lung disease and airway clearance, and we'd like to thank Debbie Breslowski, our NTM support group leader liaison, and Dr. Ashley Lozier, an assistant professor of medicine at Yale University School of Medicine, for helping to put this whole session together for us. Dr. Lozier is originally from Canada. She completed her undergraduate studies in biology at the University of New Brunswick in Fredericton, New Brunswick. She then attended medical school at Saba University in the Netherlands Antilles, residency in internal medicine at Norwalk Hospital in Connecticut, and fellowship in pulmonary and critical care medicine at Yale University, graduating in 2019. She has since stayed on at Yale as faculty and is an assistant professor at Yale School of Medicine and an assistant program director of the Pulmonary Critical Care Fellowship with a clinical focus on bronchiectasis and chronic pulmonary infections such as NTM pulmonary disease. Our second speaker of the day is Dr. James Shepard. Dr. Shepard started out as a molecular biologist, went back to medical school at Columbia, residency in internal medicine at Beth Israel in Boston, and did a fellowship in ID at Johns Hopkins, and then spent 9 years in sub-Saharan Africa and India establishing tuberculosis and HIV treatment and research programs. He then returned to the United States in 2014 as a faculty physician at Yale School of Medicine, where he focuses on treatment of mycobacterial infections. And our third and final speaker of the day is Marjorie Cullinan. Marjorie is the operations manager in the Department of Respiratory Care at Yale New Haven Hospital, overseeing the pulmonary function labs, exercise testing, and outpatient respiratory care. She's a registered respiratory therapist and registered pulmonary function technologist with a specialty in neonatal and pediatric respiratory care. Marjorie is a consultant to the National Board of Respiratory Care with more than 13 years of experience in outpatient cystic fibrosis management, having been trained in airway clearance techniques by the CF Foundation. Particular areas of interest for Marjorie are breathing techniques, airway clearance, exercise as a form of airway clearance, sputum induction, pulmonary function, and exercise testing. For today's session, you can type your questions into the Q&A box. You can, if you want to submit your question anonymously, you check the send anonymously button. When you've typed your question, you hit the send button. We have a record number of attendees at today's session, so we will answer as many of the questions as possible, but it's not likely we'll be able to get to all of them. So we will be keeping a copy of all the questions, and we will get answers to the questions that didn't get answered, and we will post those online and send them out. We send out a link to the recording of the webinar. We'd like to thank our supporters over the last year, including INSMED. The support of companies like INSMED and support from people like you allows us to continue offering wonderful programming like this. Don't forget to follow us on social media. We're on Facebook, Instagram, YouTube, where you can find an archive of all of our former webinars, LinkedIn, and the app formerly known as Twitter. And also, we are holding our first in-person patient conference since 2019, and we're very excited about that, at the Fairmont Grand Del Mar in San Diego, California on May 16th and 17th, 2024. More information and registration will be forthcoming in the next week. Thank you so much for tuning in, and I'm going to hand it over now to Dr. Lozier for the first session.
Thank you so much for the kind introduction, and I'm so excited to be here and be able to participate in this webinar for NTMIR, and happy to be participating with my expert colleagues in ID and respiratory therapy here today. So let me get my slides pulled up. Okay, so I'm going to be talking today a little bit about NTM pulmonary disease and really the diagnosis and determining when to treat. I have no disclosures for today, and I'm really going to try to highlight some of the questions that had come up before we set up this talk, addressing how to make the most of your doctor's visits and any potential advanced planning that you could be doing as you go towards your visits, and kind of what workups you want to be thinking about as you start going through your workup with your physicians. So my objectives for today are really to highlight some of the epidemiology and patient risk factors for non-tuberculous mycobacterial pulmonary disease, and I'll be addressing this generally as NTM-PD. I'll discuss the diagnostic criteria and then specific rationales on the timing of treatment initiation, with a brief review of some of the treatment options, although much of this will need to be guided based off of your outpatient follow-up with your physicians, and then the concurrent monitoring that can be addressed with some of these specific medications. So just to highlight, what are non-tuberculous mycobacteria? So these are characterized by slow growth. They have structures with thin peptidoglycan layers and lipid-rich outer membranes. There's many different species that have been identified, and they typically are cultured in the lab on special media, typically with fluorochrome staining or as with Zeal-Nielsen staining. We have slow growers or fast growers, and you'll often hear us refer to this in clinic, as these have specific implications in terms of treatments and diagnostic methods on the cultures as well. The most common one that we encounter is with a lot of our patients is our slow-growing mycobacteria, such as Mycobacterium avium complex. It typically is reported on your laboratory specimens as a complex, although depending on the laboratory, they may actually identify it based off the species as either Mycobacterium avium, intracellulare, or chimera. And those are the mycobacterium that make up MAC, or the complex. Conversely, is you may have rapid growing mycobacterium, which the common ones that we typically encounter are Mycobacterium abscesses, and depending on the laboratory, you may actually get the subspecies identified as well. So what makes a slow grower versus a fast grower is really the duration of time it takes for it to show up positive on culture. So slow growers, such as Mycobacterium avium, typically take greater than 7 days to show up on culture, versus fast growers may actually show up much quicker at less than 7 days. And with regards to the geographic distribution of NTM within the US, MAC is generally the most prevalent as it's populated around the United States. This is a nice schematic looking at the incidence of MAC across the US. As we can see, in much of the areas in the United States, MAC makes up more than 60% of the NTM species that are identified. Where we are right now, well, us being myself and our other panelists, we are located in Connecticut. So MAC actually makes up greater than 80 to 92% of our current NTM species on our geographic distribution. Throughout the rest of the United States, we all see that we have different proportions of Mycobacterium abscessus that's present, and then other species make up the remaining aspects of our distribution. And it should be noted that the incidence and prevalence of NTM has been increasing over the past 10 to 20 years within the United States and really worldwide. On this schematic here, we have the incidence of 2008 versus 2015. And as you can see, there's increasing dark blue that's showing up on both graphs on the top and on the bottom, suggesting that we've had rising numbers of incidence and prevalence of NTM species within the United States. Additionally, we do see that NTM prevalence increases with age. So on this first graph over here, as individuals get older, we start seeing that the total number of NTM prevalence increases. That's on the right screen, the age as it goes up. So those who are 80 to 90 have the highest prevalence. And then we see that on the left, gender, that within the female gender, we do have most prevalence, and then in the male gender, there tends to be a less prevalence. But again, as the age goes up, we see that both have a rising prevalence. There's also some implications that climate change could be contributing to these rising rates of NTM infections. There are studies completed in Australia that were completed over the decade of 2001 to 2016, and they showed that there was rising incidence of NTM. And a lot of this was thought to be suggested by variations in temperature, rainfall, and as potential implications to the environmental exposure to NTM. So a lot to do with the creation of aerosols and different amounts of rainfalls and eutrophication within the soils, potentially contributing to aerosol inhalations. But largely, a lot of what we're trying to focus on are what are the potential risk factors for any individual who could be becoming infected with NTM. And a lot of it comes down to this overlap between the environment and the host, and potentially host susceptible phenotypes that might be contributing as well. So as I mentioned, climate change and as a potential environmental exposure, we often are focusing on things like other ways to mitigate environmental exposure. So there's often a lot of discussion surrounding aerosolized water. So we often will ask you in clinic, potential exposures to hot tubs, shower heads, saunas, things like that, where you may have aerosolized water exposure. And additionally, you may ask us frequently, or we may ask you frequently in clinic if you are an avid gardener, as aerosolized soil could be a potential source for NTM species as well. The other part to think about is that not all hosts who do use hot tubs, pools, or showers frequently are getting infected with NTM species. So you have to think about how normal hosts, the size of the inoculum matters. So how much you're inhaling at any potential exposure could be potentially one of the triggering insults that could potentially put somebody at risk of getting this infection. There are some suggestions that living in southeast regions of the United States or in other areas of high incidence of NTM could be a potential exposure-related insult, but this largely depends on other factors that could be overlapping, such as the host. So then we move on next to host susceptible phenotypes. And this is really looking at particular patterns of patients that tend to be more commonly infected by NTM. So we commonly use the phrase of host susceptible phenotypes, and the classic one that we refer to is Lady Windermere's syndrome. And this was based off of Oscar Wilde's description of Lady Windermere's fan. So typically an older female who was thin in body habitus, and some of the associated abnormalities that could be associated could be pectus deformities, scoliosis, and mitral valve prolapse. But most commonly on a lot of our patients who present with this type of phenotype, we're looking at bronchiectasis, specifically in the right middle lobe and the lingula being the common areas. And these are typically patients who present with what we call a nodular bronchiolitis or bronchiectatic phenotype on our chest imaging, such as our CAT scans. Conversely, we have another host susceptible phenotype, which is that of older males. And this is typically classified as those who may or may not have a smoking history or some evidence of COPD on their imaging or on their pulmonary function tests, and oftentimes have associated findings of fibrocavitary or lesions noted on their CAT scan images. This is thought to be a more rapidly progressive phenotype. So this is something that we're always kind of looking for to see if patients may fall within specific host phenotypes. Then we go on to potential risk factors that could include host genetic abnormalities or potentially acquired structural changes to the lungs. So here on the right of the screen, I have potential genetic etiologies that could contribute somebody as at risk of becoming infected with NTM. And a lot of this is really just looking at genetic causes of bronchiectasis. So if you follow in a bronchiectasis clinic, we are often talking about screening you for other potential reasons for your bronchiectasis, including things like cystic fibrosis as a common genetic screen, alpha-1 antitrypsin deficiency as another common genetic screen, and primary ciliary dyskinesia, amongst other genetic etiologies that could drive bronchiectasis. And then on the acquired side, we have multiple things that could be contributing to structural lung disease. Chronic aspiration, reflux, or GERD are pretty common that we'll be asking questions about or screening for, as we know that that can contribute to recurrent inflammation in the lungs. Pneumoconiosis are typically things like in occupational inhaled injuries that you may have that could cause injury to the lungs. Smoking is a very clear one that as patients we're often screening for in our clinics. And then we start looking at things like medications or prior chest infections that could have contributed to structural lung changes. So within the realm of medications, we're always looking for immunosuppressant agents, which are pretty common depending on other underlying medical conditions, or inhalers with inhaled steroids. So next is, as I mentioned, this risk factor of inhaled steroids. We're always looking at this because this is a very common medication used with patients with asthma, along with potentially post-COVID. We do see a lot of patients having post-viral bronchospasm and requiring inhaled corticosteroids. So the risk of NTM does tend to increase with moderate to long-term use of moderate to high doses of inhaled corticosteroids. And this is really nicely illustrated in this paper from 2017, where we did see that at moderate to high doses that there was an increased risk of NTM pulmonary disease. And then there's immunologic agents that could potentially increase the risk for NTM infection. So pretty common medications, depending on your underlying comorbidities. Patients who have rheumatoid arthritis are sometimes eligible for wonderful medications to help blunt inflammation. These are often called TNF alpha inhibitors. And as part of the workup, when patients go on these medications, they're screened for tuberculosis. But something that we have to think about is NTM species as well. We do see that on patients in general population, there generally is not a big significant difference between NTM and TB. But once we start accounting for patients with rheumatoid arthritis, there is some increased proportion of those patients who may have bronchiectasis as well. And we do start seeing that NTM and TB do start to separate out a little bit more. But specifically in this population, if they do get infected with, or if they do get treated with anti-TNF alpha inhibitors, the risk of TB and NTM species does go up while being on these medications. So it is something that should be monitored for as patients are starting onto these specific medications. So next up, when we start thinking about the risk factors that could put somebody at risk for acquiring an NTM infection, we have to now start thinking about how do we actually diagnose our patients who are at risk with NTM pulmonary disease. And this comes down to multiple factors. This is from the ATS, or American Thoracic Society, and Infectious Disease Society of America guidelines from 2020. There is a specific criteria that we do follow to meet this diagnosis. So we look at clinical features, which I'll get into, and then radiographic features, and then lastly, microbiologic features. So this comes down to your cultures, which is absolutely needed before you can obtain a diagnosis of non-tuberculous mycobacterial pulmonary disease. And this can either be in the form of sputum cultures, something that you cough up spontaneously, or in the form of a bronchoscopy sample, where is it at that point in time, you only need one sample for that versus two samples if it was to be a spontaneously expectorated sample. The clinical symptoms that are common in patients with any NTM pulmonary disease, be it from like the MAC cohort or from patient online surveys, typically do involve symptoms of cough, sputum production, and predominantly fatigue, amongst other symptoms. You'll often hear us ask questions of, are you having fevers or night sweats or weight loss in clinic? And that's because those are the common symptoms that are associated with NTM pulmonary disease. And then, as I mentioned, we go from the diagnostic criteria looking at clinical symptoms now to looking at radiographic findings to suggest NTM pulmonary disease. And we often break it down into phenotypes of nodular bronchiectatic or fibrocavitary bronchiectatic disease. And what that means is nodular bronchiectatic is that you have enlarged airways of bronchiectasis, and you may see that you have little areas of tree and bud nodules commonly reported on imaging. So that would be the classic phenotype of nodular bronchiectatic. Versus cavitary, you can see that there's a cavity in the lungs, which almost looks like a rimmed hole, but it's an infected cavity within the lungs, so it is classified as fibrocavitary. And our decision to treat really does come down to looking at multiple factors before we initiate treatment for MAC. We're ultimately looking at host factors. So as I mentioned, as we were going through risk factors for acquiring NTM pulmonary disease, we look at the age of an individual, their underlying comorbidities that could place them at risk of having progressive disease or potentially not being able to tolerate the medications. And really that is largely because of potential interactions or whether or not there could be some underlying renal or liver insufficiencies that could be predisposing them to increased risk with medications. And then perhaps the most important is really looking at what our patients desire with these treatments, because we know that there's side effects that can be associated with them. So trying to focus in on what is the goal here? Is it going to be for cure of the disease or controlling symptoms to help us with quality of life metrics? And as we go forth, as we start looking at disease severity and disease progression. And as I mentioned, there are some risk factors that patients have that may predispose them to more rapid progression. Fibrocavitary disease is typically one of the things that makes us as physicians more likely to want to look at treatment more rapidly. And then looking at the severity of symptoms. So weight loss, fever, the amount of productive sputum or hemoptysis, and whether or not those symptoms are worsening over time. And then looking at the microbiologic data. So if somebody has a high burden of positive cultures, or if it's positive on smear at the beginning of a culture, that often suggests that somebody may have a higher bacterial burden at that time. And then other factors that play into our decision to treat may come down to what the actual NTM species is that's isolated. So as I mentioned at the beginning, the slow versus rapid growers on the schematic, whether or not somebody has immunosuppression that needs to be treated with. So as I mentioned, that anti-TNF alpha therapy for rheumatoid arthritis, that could be something that we may need to monitor more closely and potentially determine if we need to start therapy earlier or not. And then ultimately, is it for lung transplantation, and Mycobacterium abscessus typically needs to be eradicated before we can consider pursuing that as a therapy as well. So it is really a fine balance between watchful waiting and initiating treatment. The ATS IDSA guidelines do typically recommend that we initiate treatment right away, as if we do hit the diagnostic criteria of the 3 factors of clinical, microbiologic, and radiographic imaging. But as I mentioned, the amount of symptoms that patients have sometimes may not push somebody to want to be on therapy because of the amount of side effects, where that could potentially outweigh what they feel as a symptomatic benefit if they're having substantial side effects from the antibiotics. So we come back to this fine balance of watchful waiting versus initiating treatment. And this is a really common clinical question that I get in clinics as to when do we actually start therapy. And ultimately, we come back to whether or not it's safe to do watchful waiting if somebody's having fewer symptoms or very minimal symptoms that they feel are manageable on a day-to-day basis with otherwise non-aggressive imaging, so non-cavitary imaging, smear negative on cultures, and potentially less virulent strains of bacteria. versus to consider initiating treatment really if we're seeing progressive symptoms, more aggressive imaging findings, or virulence of the NTM species. And the reason that we want to treat really from the get-go when we're seeing progressive symptoms or more aggressive virulence of NTM is really because NTM species are associated with decreased quality of life, increased comorbidities, and mortality. And as I mentioned, is if we will often go back to weighing in our risk factors for NTM progression, and this is really a patient-physician discussion to really identify your host factors and your lab factors and your radiographic factors that may predispose you to more rapid progression before deciding whether or not if you want to pursue treatment at that time. And this may depend on your age, it may depend on your underlying comorbidities, as I mentioned, whether or not you need to be on immunosuppression. And then things to look at are whether or not your weight is within a normal range, as we know that lower BMI is often associated with more rapid progression of NTM pulmonary disease, along with a decrease in lung function as well. And then looking again, is it get the laboratory factors to suggest is it increased inflammation in the body, radiographic factors, and the sputum virulence and bacterial load. So the question that we often get is, what if I do not pursue treatment? Am I going to progress without treatment? And there have been some studies looking at patients who chose to forego starting treatment and whether or not they actually had some progression. To caveat that with, a lot of these studies have not had long-term follow-up, and ultimately, this is perhaps one of the longest ones that I found, and I will walk through this, but this one really only goes out to about 3 years after diagnosis. So this study looked at about 1,300 patients who met the criteria for MAC pulmonary disease, and they excluded anybody who had cavitary findings, so that ultimately cut it down to about half at around 700 patients. And then they made sure that patients were having at least a 3-year follow-up. So those who were lost to follow-up were excluded, and it came back down to about 500 patients. So amongst the 500 patients who were followed for 3 years, over 300 of those patients actually were noted to have progressive symptoms and ultimately underwent treatment. But about 200 of those patients did not report having progression. And 200 of those patients did not start treatment. And then once 25 of those patients, once they got past 3 years, actually started to have progressive symptoms at that point in time and started on treatment. So the take-home point from this is that you may not have progression, but ultimately over time, many patients will start to have some sort of progression and ultimately end up on therapy. So this was a nice CHEST article from 2022, and this really did look at watchful waiting as how it would impact patients. Again, this is only following for more than 6 months, so this is a pretty small time shot as if we're looking at the grand scheme of timing. But watching patients who chose to not undergo antibiotic treatments for more than 6 months, this was not associated with any increased risk of death at that time, and also did not have a lot of patients spontaneously culture convert to negative. So if you're plugged into a medical system where you were able to have some watchful waiting, it is something that you can discuss with your physicians, whether or not you want to be monitored closely and continue to follow up for any signs of progression before you start treatment. Or if starting treatment, depending on your symptoms and your risk factors, if we need to start treatment more rapidly, you're at least plugged into a medical system so that you can have that initiated at the time that it's required. I think most importantly, to highlight the non-pharmacologic therapies of NTM treatment, especially if patients are choosing not to start therapy, or even in those who do choose to start therapy, we need to have other non-pharmacologic options to help complement that treatment. And we're so fortunate today to have Marjorie Cullinan be able to share her expertise on airway clearance. So this is what I'm showing here with our percussive vest, but also looking at other factors that you can modify within your life to try to help prevent you from having more risk for progressive disease or potentially even reinfection after you've underwent successful treatment. So modifying your diet so that you can maintain adequate BMI or weight, making sure that you're controlling things like reflux, maintaining aerobic activity to maintain muscle mass, respiratory muscle strength, and also to augment your airway clearance, and then avoiding any inhalational exposures that could be potentially injurious to your lungs. I'm not going to focus much on airway clearance since we have Marjorie talking to us about this after. But just to really highlight that chest physical therapy in bronchiectasis and NTM is associated with improved quality of life, exercise capacity, reported symptoms, pulmonary function, and exacerbation rates. And this again was highlighted in NTM patients, not specifically just bronchiectasis patients, where NTM patients who underwent airway clearance did have decreased cough and sputum productions when followed for 2 years, even if they were not on antibiotic therapy. So treatment regimens largely for MAC do vary based on imaging abnormalities. So if you have an initial phenotype of nodular bronchiectatic, you may be eligible for a 3 times weekly regimen. And it is typically the classic regimen of a 3-drug containing regimen, including azithromycin, rifampin, and ethambutol. But there may be variations in this depending on susceptibility patterns. Then for more severe disease of those who have cavitary lesions or were previously treated, you may look at the similar regimen as daily plus an IV antibiotic as well. And then I'm not going to focus on Mycobacterium abscessus or the rapid growers at this time point, but a lot of what that regimen will entail is largely based on genetic mutations to suggest any potential resistance patterns. And then that largely has an initial period that contains an IV antibiotic and then multiple oral agents as well. But this is generally well designed with your medical team, including consultation with your ID and pulmonary physicians. So a common question I do get in clinic is, what potential side effects do I need to be monitoring for in my NTM pulmonary disease? So if we're looking at the common regimens that are brought for MAC, these typically include a macrolide, ethambutol, and rifampin. And then there's the question of amikacin, either the IV or the inhaled version that may be added to some regimens. Common things that we need to watch for in a lot of these are typically GI side effects. So it's a pretty common symptom that we have a lot of our patients present with after they start antibiotic therapy, but we're also monitoring for QTc prolongation, which entails patients getting monitored for their heart. We're often recommending that patients get their eyes and their ears checked just because of potential toxicities that can happen with several of the medications, including the macrolides, ethambutol, and the amikacin. And then laboratory monitoring can vary depending on how you're tolerating medications, but we'll often start with frequent labs at the beginning and then space them out depending on how you're tolerating medications. And then when we have patients who start on their antibiotic therapy, we're frequently checking mucus cultures to see that whether or not these antibiotics are working effectively at causing your cultures to turn negative. And what happens when they do not is a definition of refractory NTM pulmonary disease. And that is, by definition, those who fail to convert their cultures to negative after 6 to 12 months of therapy. And there's a lot of different factors that can contribute to this. Medication adherence is from potentially not being able to take medications due to side effects, whether or not you have potential resistant strains or have had prior MAC lung disease, potential host factors, or development of cavities, making it hard for the antibiotics to work. So a lot of different factors that may need to be assessed if you do run into having refractory NTM disease. And really, from the most recent guidelines in 2020, this was one of the newest additions to medications that were approved, which is inhaled liposomal amikacin. And this was found to be approved for refractory MAC lung disease. So those who failed to convert their cultures with guideline-based therapy at 6 months, with the addition of ALIS, or inhaled liposomal amikacin, we found that there was improved sputum conversion with the addition of this inhaled antibiotic to ultimately be able to have patients convert their cultures and come off therapy. And a follow-up study to this really just looked to see how sustainable or durability using this inhaled amikacin was. And ultimately what they found was that patients were able to maintain negative cultures for the most part coming off of therapy for 12 months. So relatively reassuring findings at this time point and relatively early phases to suggest that this is going to be a sustainable culture conversion. So I think heading on to our last part of this is looking at what's on the horizon for NTM pulmonary disease in terms of research and potential clinical trials. So this is a slide from a couple of years ago in 2018 that really highlighted the pipeline of NTM drug discovery. Much of these are still in the works at this point in time, but we do have drugs in the discovery phase, and then we have multiple phase 1, 2, and 3, and 4 trials that are ongoing for different aspects of NTM pulmonary disease. There's some other ongoing trials looking at omadacycline for Mycobacterium abscessus. There's some trials looking at nitric oxide to try to enhance host defenses. And then there's other antibiotic trials going on looking at a 2-drug regimen versus a 3-drug regimen, along with additional trials of liposomal amikacin. And then also in the development phase, there's some studies looking at bacteriophage for the use of treatment of drug-resistant Mycobacterium abscessus and other NTM species. There's also lots of bacteriophage research going on looking for other bronchiectasis bugs, in particular Pseudomonas, for a lot of these drug-resistant bacteria. And this is just a nice example from a couple years ago of a cystic fibrosis patient who had disseminated Mycobacterium abscessus and ultimately was treated with this phage cocktail and had a substantial reduction. If we look at before treatment, you can see all these darker regions that are highlighted on the scan, and then post-treatment with the phage cocktail, that there was actually a reduction in the amount of the Mycobacterium abscessus there. So quite promising developments that could be in the pipeline as well for potential treatments. So just to conclude, NTM infections are definitely becoming increasingly prevalent, both within the United States and worldwide. We have to look at our host risk factors and environmental risk factors when we're diagnosing patients with NTM pulmonary disease, and looking at what are the potentials for risk factors for progression, and then look at that to try to time our treatments to see what's the risk benefit of starting treatment and the risks of progression. Lastly, treatment regimens include non-pharmacologic and antimicrobial options, and there's a lot of collaboration between respiratory therapy, ID, pulmonary, amongst other specialists as well. And then always keep checking back with your physicians, with your patient liaisons, and other online resources to look for any potential new clinical trials or research opportunities if you're looking for additional options or new insights on potential therapeutics. So thank you for having me, and we're a collaborative event, or a collaborative program at Yale. So we work really closely as a group together, and thank you again for having us today.
Thank you very much. I believe next up we have Dr. Shepard. So I'm going to turn the podium, such as it is, over to Dr. Shepard to continue the discussion.
Thank you. Thank you very much, Amy. And thank you to everybody that's dialed in. I see there's over 400 people, which is one of the biggest groups that I've spoken to. The last time I spoke to so many people was right at the beginning of COVID in February 2020, which you might imagine was a fairly hectic time for infectious disease doctors, and giving talks and reassuring or not reassuring sometimes. And I remember watching the participants click up to the largest number of people I've ever spoken to, certainly more people than I probably ever met in my life, of over 10,000 in February 2020 as the pandemic rolled out. But clearly, the amount of interest in NTM and pulmonary non-tuberculous mycobacterial infections is extremely high. And this organization is obviously of enormous value to people suffering from this disease. And the interest is remarkable. I think we're all very pleased from the Yale group to be able to offer ourselves as conciliaries, as advisors and treating physicians to help you through what is really an extremely challenging condition. I don't have any slides, and I'm quite glad I don't, because Dr. Lozier just gave an extremely comprehensive talk on all of the aspects of NTM pulmonary disease. And so what I want to do is to highlight some of the aspects that are important points of collaboration between the different sets of doctors and technical people and therapists that are all critical in helping to manage this increasingly prevalent condition. I will emphasize that it is an infection, but like all infections, and even more so perhaps with NTM pulmonary disease, it is also a disease of a very specific host. And as infectious disease doctors, we always take great consideration of the host that we're dealing with and what are the risk factors of that host for the infection that they've acquired. And for pulmonary NTM disease, obviously, Dr. Lozier went through clear risk factors in the lungs. And number one, a background of structural lung disease from whatever cause, and she mentioned a very comprehensive list of causes from genetic, things like cystic fibrosis, all the way through to environmental and social causes like cigarette smoking or prior infections, ultimately causing structural lung disease, and in particular bronchiectasis with inflammation of the airways and fibrosis of the airways, such that they no longer clear themselves. And secretions, which are a natural production of the mucosa, the lining of the lung, pool deep down in the lung rather than progressively get cleared upwards via the mucociliary escalator up into the larger airways and then out into the mouth and often swallowed or coughed out. And it's that host factor that is, if not the most important, certainly half of the importance of the infection of pulmonary NTM. And the other factor, which Dr. Lozier mentioned, and which really falls much more into my lap, is the organism that takes advantage of this structural lung disease, and that's the non-tuberculous mycobacterium. You've heard a little bit about my biography. I spent most of the first part of my career internationally dealing with TB, or Mycobacterium tuberculosis, which remains one of the world's most important infectious diseases. But increasingly globally, and definitely much, much more common in the United States, is non-tuberculous mycobacteria. And they are extraordinary organisms. They're environmental organisms. So as Dr. Lozier mentioned quite clearly, they are present all around us all the time. They're in our water supply, they're in our soil, they're in our houses, in our medical offices, in our mouths. You can isolate non-tuberculous mycobacteria, particularly the slow-growing versions that Dr. Lozier mentioned that we call MAC. And so most people without structural lung disease do not get infection with this ubiquitous environmental organism that is all around us and being inhaled, presumably, by all of us all the time, because we clear that introduction of the organism. But a certain subset, the people that have already been highlighted, cannot clear the organism, which then hypercolonizes really the airway and grows externally within the airway in the secretions and thickens them up, infects them, and makes them harder to clear. And so these two components are the critical components. And patients often will present first to a lung doctor because the symptoms that this overgrowth of mycobacteria deep down in the airways produce suggests a lung infection, and a chronic lung infection with cough, fatigue, easy fatigue, decreased exercise tolerance, weight loss, that become a pulmonary syndrome that they then go to a lung doctor. Some of them come to infectious diseases first. Sometimes a lung doctor will have sent their sputum for smear and culture, and it will come back with MAC, or one of the other non-tuberculous mycobacteria. And an infectious disease doctor may be the first person available, or their GP may decide that this is an infectious disease rather than a host factor, a pulmonary syndrome. So patients can come to infectious disease first, but usually I would say that they come to a pulmonary practice and a pulmonary disease physician like Dr. Lozier first. And in the most common non-tuberculous pulmonary syndrome caused by MAC, there are clear guideline-based therapies that most lung doctors would feel comfortable prescribing, as Dr. Lozier already mentioned. Things like oral 2 or 3 drug guideline-based treatment with azithromycin and ethambutol, or azithromycin, ethambutol, and rifabutin, one of the rifamycins. And often those patients will get better. Dr. Lozier clearly outlined the trajectory of people once they begin treatment. Often they won't, or they will get better and then they will relapse, or perhaps they will get reinfected. And often we will see those patients as infectious disease doctors referred from pulmonology for more assistance with a patient that started on a guideline-based oral regimen and now needs more help. Their symptoms have returned, their sputum cultures have returned, and they will require assistance from infectious disease. And each individual case is really managed as an individual. At that point, the guidelines become a lot less certain because the numbers of patients that have been studied in these particular cases are no longer as great, and expert opinion and infectious disease input on how to manage an organism like MAC, a slow-growing mycobacterium that can accumulate lots of drug resistance, can replicate in biofilms within the airways, as I mentioned, which are strictly outside of the body. They are harder to treat than infections that get into inside your body, as it were. And so we get involved at that point with perhaps intravenous antibiotics. Dr. Loja mentioned some of the newer inhaled antibiotics, amikacin. Initially, there are some others in trials. So certainly at that point, a collaboration between pulmonary doctors and infectious disease doctors is very important. I would also point out that although the majority of pulmonary MAC, pulmonary NTM infections is MAC, there is a significant proportion that are different NTM. And the main one that we see that comprises perhaps 10% of pulmonary NTM is M. abscessus, one of the rapidly growing mycobacteria. And this is a much, much more challenging organism. It has multiple constitutive, which means it has chromosomal resistance mechanisms that it was born with, as it were. And so it is inherently resistant to a far wider spectrum of antibiotics than pulmonary MAC, MAC itself, which generally is susceptible to the oral antibiotics initially. And so for M. abscessus, I would recommend that pulmonologists and infectious disease doctors, plus all of the extra airway clearance and respiratory therapy, be available right from the start. And for M. abscessus, we routinely use multiple intravenous antibiotics during an early phase of the treatment because the treatment is so challenging. And unfortunately, because treatments are less efficacious than the treatments for MAC lung disease. And so M. abscessus patients tend to do less well and need more changes in their drugs and more review of the initial and subsequent treatment. And so they very much benefit from an immediate and close collaboration between pulmonologists and infectious disease doctors. I want to leave lots of time for Marjorie because I think that she's a critical component of all of our both pulmonology and ID approaches. So I just want to finish by highlighting that there's not just infectious disease doctors and pulmonologists that are important in management of NTM, lung disease. There are two other groups, certainly at Yale, that we're trying to incorporate in our practice more effectively for our patients. And that is the lab medicine specialists, who are the ones that culture your sputum and determine the drug susceptibility patterns of your MAC or your M. abscessus, or perhaps one of the rarer mycobacteria, and give us the critical information that we need to develop and design antibiotic regimens for you. And that is an extremely important component that really isn't hugely effectively linked in with our practice yet. And that's a focus that we want to improve upon. And the recent patient that we managed together benefited from surgery. TB, a long time ago, used to be called a surgical infection, where parts of the lung that were so damaged and perhaps infested with mycobacteria, there were so many organisms and so much structural damage that a thoracic surgeon would do a lobectomy or remove that section of lung, thereby reducing the burden of bacteria and also removing the non-functional lung parenchyma. And we still do that. Mycobacteria are very challenging organisms, as I think I've already said several times. And sometimes surgery is an adjunctive therapy that allows us to clear up the remaining organisms once the majority of them in the damaged lung have been resected by a cardiothoracic surgeon. So 4 different groups of health providers are critical for the best outcomes for patients like yourselves. And we certainly hope at Yale to get better at integrating ourselves so that you get what you need when you need it. And I will stop there and leave the rest of the time for Marjorie. Thank you very much.
Thank you, Dr. Shepard. Marjorie, the floor is yours.
Thank you so much. All right. All right, we're going to talk about airway clearance. Who's excited? I'm excited. This is one of my favorite groups to talk with and talk to because you all are so interested in helping yourselves to get better. So we're going to talk about a bunch of things when it comes to airway clearance. Just make sure I can move my screen. There we go. So I'm going to give you just a bit of disclaimer. So the last 2 speakers were physicians, and I am not a physician. I'm a respiratory therapist, and I am very proud to be a therapist in that I help to treat the lungs and to help you to feel better, and sometimes with different things that aren't conventional to medicine. So we use movement, we use breathing to help you get better. So there are recommendations that I'm going to make during this talk that are evidence-based, and they're also offered things like manufacturer recommendations, and they may be different than what you have heard from your provider specifically. And also, your provider may choose a different care plan than the things that we discussed today, but it is my purpose to educate you and have you armed with the most information that you can possibly have to take really good care of yourself and the condition in which your lungs are in. So today is all about tools. It's all about information. And please feel free to add questions to the chat if you have something specific that you want me to answer. So my objections in this talk, we're going to review the purpose of airway clearance just in general. We're going to talk about different breathing techniques that you may have been taught about or you may not have been taught about. Respiratory therapists are not standard in every pulmonary clinic, so we want to make sure that you know what's out there and how to get information about breathing techniques that may be beneficial to you. Positions and movements that help to augment airway clearance. Just give you some more bang for your buck. And then at the end, we're going to go over some cleaning and sterilizing of nebulizers, and in particular, sort of our pickier nebulizers that are harder to clean. So when it comes to cycles of pulmonary infections, and this has to do with bronchiectasis, this has to do with NTM, this has to do with any pulmonary infection out there. Our lungs react in a similar way when there's foreign things in them. So if a bacteria gets into your lungs, you end up with an infection. And with an infection comes mucus production. With mucus production can come inflammation. And then inflammation can become more infection. And it becomes this vicious cycle where your lungs are really trying their darndest to protect themselves and may actually be making matters a little bit worse in that mucus production. So what we're trying to do with airway clearance is break the cycle so that you're moving mucus out of your lungs. You are removing the medium that bacteria can live in so that you can help to make your lungs healthier. Your providers, your doctors prescribe antibiotics and other medications for you, but we want to be actively part of making our lungs better. So, what's the benefit of airway clearance? So, like I said, anybody on the planet would benefit from airway clearance if they're having lots of mucus or have a lung infection themselves. So your doctors are already treating your bug. We want to make your lungs a place that are not a great environment for bacteria to live in. So naturally, your bacteria loves to live in dark, warm spaces, and your lungs are just that. And your lungs, as an organ, it's a particularly squishy organ. So bacteria likes to tuck itself way into the dark spaces. Bacteria also likes to live in sticky mucus, and that stickiness can make it hard to cough up. Airway clearance is a way to evict the mucus and bacteria from your lungs so it doesn't have a place to live. So along with your antibiotic therapies, airway clearance can help you feel better and help actually make you feel better faster than antibiotic therapies will make you feel that way. So when we think of airway clearance, oftentimes we think about devices, right? So I don't know if it's as Americans or in this day and age, we all want something that we can tangibly hold or have in our home that will just help us get better, right? Take a pill, plug into a device, this is going to fix me. But really, at the core of all good airway clearance is the breathing, the coughing, and the actively participating in our clearance in order to get mucus out of our airways. Because any of these devices, if any of you have them, they can make you cough, they can mobilize mucus, but you actually have to do the work to get it up and out of your body. And when I say up and out, I just want to be clear that it's really up and out of your lungs. When we are clearing mucus, sometimes it just comes up to our throats, and it can be okay to swallow mucus that does come out as long as it doesn't bother your stomach. So it's not causing any additional problem if mucus comes out to your throat and you swallow, but we don't want it to cause you to have a decreased appetite or a sour stomach or even to feel nauseous. So in those cases, we want you to completely get it out. We'd love it completely out of your body in an ideal situation, but I know even in myself, sometimes only getting it up to my throat is as far as it will go. So I have this great respiratory therapist that English is not her first language, and she would always explain airway clearance in terms of sort of a metaphor or an analogy. So we're going to look at a peanut butter jar as our analogy. So I don't know if any of you have small children, small grandchildren, and they're constantly consuming peanut butter, but cleaning out a peanut butter jar is not easy. So how do you clean it out? So the first thing you do usually, because we don't want to put that much effort forward at first, is we fill the jar up with water to soften or thin the peanut butter. Then we may shake the jar up and down, try to loosen that peanut butter from the walls of the jar. But eventually, we end up having to scrub out the inside of the jar because we're all good recyclers and we want to make sure that we have a nice clean jar to put in our recycling bins. So of all those different steps, in the end, we had to do a bit of work in order to get the jar completely clean. So thinking about our lungs as a peanut butter jar, when it comes to airway clearance, you can nebulize medications that can open your airways and thin your mucus. You can use your acapella or aerobica or your vest to shake the mucus free from your airways. But in the end, you really need to take the time to actively participate in breathing and coughing techniques to clear your mucus from your lungs and to help them to get better and for you to feel better. Because in the end of all of this, Dr. Shepard, Dr. Lozier, and I want you to feel better. That is why we get up every single morning, is to help you to feel better in your life. So we're going to talk about breathing techniques. There are 3 breathing techniques that I'm going to cover, and the first of which is huff cough. And this is definitely the most popular mode of airway clearance in terms of breathing techniques. And the reason it is the most popular, it's pretty easy to teach, it's pretty easy to do, and I'm going to ask you to do it in every single other type of breathing technique that we do. So what a huff cough is a deep breath with a breath hold and a complete exhalation until you can't blow out anymore. For those of you who've done pulmonary function tests, you know when we say blow, 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 right? We're trying to get all the air out of your lungs. And by moving all the air out of your lungs, we're able to mobilize mucus a little bit more easily. So it's an important part of airway clearance because the deep breath that you take in helps you to get air behind mucus so that you have some power. Holding your breath helps you to expand your lungs and really use the full capacity of your lungs when you're going to force air out. Then a forced exhalation helps you to move mucus up and out, and the huff itself is called a huff cough, but that's a bit of a misnomer. It's more of a huff breath because we're not going to cough and close our vocal cords. We're going to leave our throats fully open so that it is a nice open door for mucus to come up and out. So we're going to practice. I do give one disclaimer. So I myself am recovering from a pulmonary infection. So for those of you who know 90s commercials, I am not just the president of the Hair Club for Men, I am also a client. So if I do cough, I'm with you because we're going to be doing lots of different breathing techniques. So we're going to practice huff cough. So I want you to start with a deep breath in, and you're going to hold your breath for 3 seconds and then blow out. And don't be afraid to make some noise. You're going to keep going, 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 going till you have nothing left. Then another one, deep breath in. Hold, 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 and out. Sometimes we call this a dragon breath because we like kids to make a nice loud noise. Deep breath in. Hold, 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 and out. A nice open throat. Keep going, keep going, keep going. And then you give one cough. By doing those breaths, you're moving mucus closer and closer and closer to your large airways so that when you do your one cough, you can power it out of your lungs. What is nice about this breathing is it's not that hard on your lungs. It doesn't cause your lungs to react. It helps you to control your breathing. It helps to expand your lungs. And you can actually use this technique as you are doing your acapella or aerobica. You can use it as you're on your vest if you use those therapies. And this type of breathing, the deep breath in with a breath hold and a long exhalation, is also beneficial when doing nebulized medications. So huff cough is at the center of all good airway clearance. The next technique that we're going to talk about is active cycle breathing. Active cycle breathing, it looks like a lot, but don't get intimidated. It's just a cycle of breathing in which you do a bunch of different types of breaths. And really, it's 3 different types of breaths. One is just simple deep breathing. Deep breath in and all the way out. You do 3 to 4 cycles of just that. The second is called pursed lip breathing. And if any of you have ever been to pulmonary rehab, this is a popular breathing technique. And it also is a very popular breathing technique in yoga. All it is a deep breath in through your nose, and then a long breath through your mouth. And when we say pursed lip, think about like your mom putting on lipstick when you were little, right? So you make like a little bit of resistance through your mouth. How you'll hear people talking about it is smell the roses. So breathe in through your nose and out through your mouth to blow out the candles. At the end of the pursed lip breathing session, you just do some huff coughs. And we've already gone over that bit. So you've got that in the books. So how it works. The deep breathing portion, you take breaths as big as you can to open up the lungs as much as possible. And then you blow it all out. This helps to give you power in your breathing, to recruit as much of your lung power as you have. The pursed lip breathing, while it's inhaling through your nose, and your nose is your natural humidifier of your body, it also gives you some warmth as you breathe in through your nose, and then out through those pursed lips gives positive pressure back into the lungs, similar to your acapella, aerobica, and PEP devices. It puts pressure back into the lungs and helps to give you volume and stamina to be able to continue with the breathing. And then your huff coughs help to keep your airways open and clear of mucus. So we're going to practice. So we're going to start with some deep breaths. So deep breath in. We're going to pause at the top of that breath and then blow all the way out. Another one, deep breath in. All the way out. One more time, deep breath in. All the way out. And now we're just going to do the pursed lip breathing. So 30 seconds of this. Normal, in through your nose, out through those pursed lips. You don't have to go as deep. You can just do nice and easy. In and out. You think yoga breathing. In and out. We're going to do one more. And out. And now it's time for huff coughs. So take a deep breath in now. Hold, 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 and blow out long. You can really, really push on these all the way out. Deep breath in. Hold, 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 and out. Don't be afraid to be loud on these if you're all by yourself. And one more. Hold, 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 and out. Good. And at this point, you would just be repeating the cycle. I love to see Debbie coughing in the background because it works. These types of breathing, it really makes you think about taking the deep breaths, taking the time, and listening to your breathing as you're doing it. Having to stop and cough in the middle is no big deal. That just means that mucus is telling you it's there. So taking yourself through these cycles helps you to just listen to your breathing and what's going on. The next breathing technique. Now this is some big stuff. Like if you can get the huff cough and you can get the active cycle breathing, this is even advanced respiratory stuff, but this group is amazing. And I want to make sure that you know about it because it's pretty darn cool if you know how to control your breathing. So autogenic drainage. This is a way of moving mucus from the outside of your lungs to the inside of your lungs. So think of your lungs as an upside down tree. The branches are the smallest on the outside and the biggest on the inside. So what we're going to be doing is we're going to use our breathing techniques to move mucus from those outside airways into the inner ones. So in autogenic drainage, we're starting with small breaths, and these are what are called in the expiratory zone. So this may feel a little bit difficult when you start because we're going to start at really low levels of breathing, but this helps to unstick mucus from the peripheral, which means the really, really far out airways. Then we're going to take some breaths in the mid-range, so kind of mostly shallow breaths in the middle of your breathing, not what you're used to in a normal breath. And this helps to collect mucus from your middle airways. So we've unstuck it and now we're collecting it. Then we take some small breaths above our normal breathing range, and this helps to move mucus out of your airways. Now, this one I get particularly stuck in this evacuate or the big breath mode because I get stuff in my upper airway and then it makes me kind of cough. So bear with me, but we are going to practice because we've been practicing this whole time. So what I want you to do is just start with normal breathing. So just find out what is normal for you. And then you're going to take a deep breath in, and we're going to blow all the way out so you have nothing left. And I want you to take little sips of air. In, out, in, out, in, out, in, out. And then you're going to take a little bit bigger of a breath, and then a little bit out, a little bit in, a little bit out, a little bit in. You might want to take a deep breath, but try to hold it back. In and out, in and out. Now I want you to take a bigger breath and only let a little bit of this out. A little bit in, a little bit out, a little bit in, a little bit out. Now take a deep breath and then all the way out till you have nothing left. Good, good. So you see how this one's a little bit trickier and it takes some breathing control. Something that helps me, and I'm just going to kind of point the camera down just for a moment, is to do this technique, I put my hands on my chest and kind of on the upper part of my abdomen so that I know where I am in my breathing. So I take my big breath in. See how my chest went up? Let it all the way out. And then when I do my little breaths, I only go up a little bit and a little bit down, a little bit up, a little bit down to start. Then my mid breaths, my hands going up a little bit more. See, down, up, down, up. Then I go down and then bigger breath in. See how much my hands are coming apart? Then down, up, down, up, down, and then my huff, deep breath in, and then good, good. So it's helpful sometimes to do this in the mirror. See how I showed you the differences in the volumes? The pictures are helpful to show you where you are in your breathing range, but knowing your own breathing range on your chest can help you with this technique. This one in particular, I have seen in person a cystic fibrosis patient who typically does vest cough just as much up in a vest session as they have doing this breathing technique alone. But you really have to be tuned in and making sure that you're listening to your breathing and you're coughing as you need. Also, with this breathing, you can kind of figure out where your mucus is. Is it in your small airways and you feel a rattle when you're at those really low volumes? Or is it in your big airways that you can feel it at your big volumes? So very, very cool technique, very, very underutilized. But you all are the perfect folks to try this out and see if it's helpful to you. So augmenting airway clearance. There are things out there that can really help you to move mucus from your lungs more easily. So postural drainage is a very, very old technique. It was actually used first in tuberculosis, when they actually would put somebody over a bar and drain mucus from their lungs. We don't plan to put you over a bar. We've changed that method a bit, but using gravity to help you to drain air or drain mucus from your lungs can be very, very helpful to move mucus more easily, along with your breathing techniques, or whether you're doing any devices or vest therapy. So in the respiratory community, we have this rule of thumb that we call put the bad side up. So if your doctor has told you that you have an infection in your right lung, sometimes it is helpful to put your right lung to the top of your therapy so that you help the mucus to naturally move towards your middle airways with gravity. And air is very light. It moves to the highest point of the body. So whenever we do postural drainage, or in the hospital, you'll have heard about postural drainage and percussion or chest PT. We always put the side we're trying to treat at the highest point of the body. So this gentleman here has one side versus the other side up, and also, if you notice, the table is tilted a bit so that his head is lower in the body and mucus can drain towards it. So really how it works is that air is light and mucus is heavy. So we want air to move into your airways. So we want for you to place your airways lower than where your infection or where your mucus lies, so that it can drain towards the larger airways. The air itself, once it passes mucus, will just naturally go to the highest point in your body, which is your small airways. So that's exactly where we want us to go. Here are various different positions. If you Google this, there are a zillion positions that you can get into in order to drain mucus. But oftentimes we'll tell folks, like, if you feel you got something stuck, like I was just saying, I'm a client of all this airway clearance. If my bad zones are my right middle lobe and my left lingula, I will lay with that at the highest point when I'm doing my breathing techniques, and I get more bang for my buck. And I also feel like at the end of it, ooh, I feel some air moving in there. And that's the desired effect of postural drainage. The only things that we want you to just be aware of if you're positioning yourself, especially with your head down, is just, be aware of how you feel during postural drainage. We don't want you to become lightheaded. We also don't want you to get a headache. So just be aware of how your head feels, how your body feels when you're in those positions. And exercise positions also promote postural drainage. So for those of you who are yogis on this call, a position like downward dog is a beautiful position to drain mucus from your airways. And actually, there are patients who do use their PEP devices with yoga. I don't know if I'm quite coordinated enough to do that, but it does work. We do have certain patients that have used inversion tables, and they are a safe way to invert yourself as opposed to being over a bar in our previous TV treatments. And then I actually myself was a swimmer. And if you ever watch swimmers warm up, especially ones like divers, water polo players, people who are going to have to hold their breath, if you ever watch them warm up, they spin underwater. So they're just kind of moving around. And what that's doing is just sort of recruiting lung and letting lungs stretch. So that can help you to move mucus as well. I know for me that when I'm swimming, which I still do every week, if I'm feeling off or have something going on, being underwater and holding my breath can be an immediate sign that something's up. So just remember, whenever you're doing any of these positions, you want to remember to take your deep breaths and do your huff coughs, because if you're going to get in the position, if you're going to do these things, you want to make sure that you get good effect from it. Some ask me, well, actually not some, a lot of people ask me, is exercise like a good form of airway clearance? Is it something that I can use as my active airway clearance as opposed to using devices? And I always give the answer of exercise is an excellent form of airway clearance as long as you're using it for that purpose, along with just the general benefits of exercise. So you want to make sure that whatever you're doing makes your heart rate go up, makes you take deep breaths. So there are things like walking at a good pace, jogging, cycling, doing an elliptical machine or rowing machines, different active aerobics, dance classes, Zumba classes, and swimming all can be good activities to take deep breaths. And with it, you're having fun while you're taking those breaths. I even tell folks it's silly, but like if you're going on a walk, go with a friend and talk. Because when you're talking, you're regulating your breathing, you're taking deep breaths, and you want to do something that you're sweating, you're exerting yourself. And then at the end of your exercise, or even during your exercise, you should be doing your breathing techniques and your airway clearance to make sure that you clear mucus at the end of it. So, because really the purpose of airway clearance is to clear the airways. So whatever method you're using, we want to make sure that you feel clear before you move on to your next activity of the day. I say, and this is, I even say to myself, use your breathing as a barometer, all right? Barometers can sense a change in pressure before the storm comes. So your lungs and your breathing can tell you if your infection is worse, better, is there an exacerbation of your infection brewing? So I tell folks, when you're doing your airway clearance, I ask, can you take a deep breath? Can you hold your breath? Is it comfortable to hold your breath? When you go to exhale fully, are you hearing a rattle? Are you feeling a rattle? Is it different than your normal? Are you coughing up mucus? What color is that mucus? How much is it? Is this more than normal for you or a different color or consistency for you? Also, are you becoming short of breath doing your normal activities? If somebody tells me, 3 times a week, I take a walk with my girlfriend for 3 miles. Now I can't talk to her the whole time that I'm walking that 3 miles, or I had to shorten the walk or take breaks. Those are all symptoms. Those are all signs that something's up that we could help you with. So use your breathing, use these breathing techniques to sense where are you at right now and what is your normal and what can we help you to improve upon. So respiratory hygiene. This is really a hot topic in the respiratory world. There are a lot of people out there who use nebulizers and for various reasons. And there's also, while we recommend cleaning nebulizers for absolutely everyone, in the cystic fibrosis, the NTM community, and in the bronchiectasis community, where we also see folks with other infections, for example, things like Pseudomonas, we want to make sure that if we're helping you with nebulized therapy, we don't want to reintroduce you to any bacteria or expose you to anything that's either outside of your body that could make you feel worse or already inside your body. And we don't want you to rebreathe that, right? If you're taking the time to do your therapies, we don't want any bacteria to go back in. So in terms of cleaning nebulizers, the instructions are pretty standard. They want you to use a warm soapy water. And the reason that it's a soapy water, and I do want to give the disclaimer that when I talk about soapy waters, none of them can contain lotions. So you want to use like a Dawn dish detergent, a Palmolive, something that you can actually see through like a gel instead of is like creamy looking like a lotion. These soaps help to dissolve the aerosols that you are putting in the nebulizer itself and what remains in the nebulizer even when you're done taking it. So it just breaks apart the particles, whether it's a medication like albuterol, it can break apart the salt particles if you're taking a saline, and you want to scrub anything inside that's visible. Oftentimes folks will come to me with a nebulizer and say it's not working. And when I look inside of it, the salt from the saline solution has sort of like made a very white precipitate type solution, or dried film on the inside, and that actually makes the nebulizer not work as well. So you want to scrub anything that's visible that looks like it could be clogging things, and then you want to rinse it with sterile water. Now I say this for folks with NTM and folks with bronchiectasis that regular water doesn't cut it. In other communities, they'll say they just rinse it under their tap, but different waterborne bacteria can be found throughout your home. You want to make sure that what you're cleaning your nebulizers with does not have any of that bacteria. So making water sterile is as simple as boiling it for 5 minutes and just keeping it in a clean container. You don't need to boil it every single time to make sterile water. In the hospital, they have it in bottles. If you're ever hospitalized, you can always ask for that for your nebulizers in between therapies. And then once you're done with the, cleaning it in warm soapy water, making sure it's nice and clean itself, rinsing with the sterile water, you want to dry in a paper towel. And I am specific to a paper towel because towels themselves, like our home towels, you notice if you just leave one on a countertop with wet things, it itself will remain wet and can potentially become moldy itself. So paper towels become crunchy and they do not hold on to water the way that other towels do. I do always get questions in terms of cleaning nebulizers. Do I need to clean out the tubing that comes from my compressor? You do not need to clean that out. The flow from your compressor to your nebulizer is one way. If for some reason you've left your nebulizer on your tubing and their liquid has gone back to the machine from your tubing, you just want to blow that out. But you do not need to sterilize the tubing itself, and the tubing is not made for sterilization, so or cleaning or sterilization. So you just might want to get a new one if you're feeling like it's too unclean. When it comes to cleaning as well, I just give this disclaimer in the land of COVID that we've lived in for as many years as we have. I feel like we should call it COVID 2024. You want to make sure that you're washing your masks if they're cloth or changing your paper masks frequently. We sometimes don't notice that when we're wearing our mask, we're coughing beneath them and bacteria can end up on the mask itself. So regular washing of cloth masks or changing your paper mask frequently can keep you from reintroducing bacteria as you're wearing the mask itself. So one step further from cleaning, because you got to remember there are folks that only clean nebulizers. There are recommendations within the CF population and within NTM to sterilize your nebulizers. And this is really to make your nebulizers as clean as possible, as almost like back to new every time that you use them. Sterilization techniques have not been evidence-based at a particular interval. As long as it's done, they consider it regularly, a couple times a week. Some people are able to do it daily, and I applaud you for being able to do so. But there's a bunch of methods that are all proven to work. These are all supported by the Cystic Fibrosis Society, and they have plenty of evidence that all of these methods work. For NTM and for things like Pseudomonas. It just depends on your lifestyle, which fits best for you. So in terms of heating methods, you can place your nebulizers in a pot on your stove, submerged in water, and you boil it for 5 minutes. The part that I always say is you want to stay with your pot, because if it does touch the side, it depends on what kind of pot you're using, you can potentially melt plastic. So just make sure that you're with it when it's boiling. It only needs to boil for 5 minutes and it is completely sterile. In your dishwasher, you can place your nebulizers on the top rack. The reason I say the top rack is if you have a robust dishwasher, the jets can throw the nebulizers all over the place. So you just want to make sure that they don't get down to the bottom rack and end up melting. So top rack for your dishwasher, running through a full regular dishwasher cycle, and it can be run with your regular plates. There's no reason why it can't be with everything else. You can use a microwave. So you take a microwave safe dish, you fill it up with water, just so that the nebulizer is submerged in the water, and microwave for 5 minutes. And that you don't need to worry about the nebulizer touching off of anything. And also you can walk away and come back, and you don't have to worry about anything bad happening. Medela, which is a breast pump company, has made steam bags, which are sterilization bags. So you want to follow the bag instructions. And there are usually the boxes themselves, they have the instructions on them. It's 2 ounces of water in the bag. Place your things in, zip it up, and then it gives you the time for how long you're going to put it in the microwave for. Usually the boxes come with 5 or more bags, and you have 20 uses per bag with little check marks on them that you can use. That is actually very helpful, and helpful for travel too. If you have a microwave in your hotel room or you're going to somebody else's house, easy to bring along with you. Baby bottle sterilizers, these are available at most like Walmart, Target, places like that. It is meant to sterilize a baby bottle, which is just as good as a nebulizer. And with baby bottles oftentimes being plastic too, it is rated for most plastic nebulizers. Then there are what we call the cold methods. So cold methods are things that we're not using heat, obviously, but different chemicals in order to eradicate bacteria from a nebulizer. So after you've cleaned it, you can submerge your nebulizer in isopropyl alcohol for 5 minutes, or you could submerge it in hydrogen peroxide for 30 minutes. And when I say submerge, like people oftentimes think of like a container and, oh my goodness, I'm going to need all these bottles. A really quick a life hack here is that if you take a plastic bag, something like a gallon plastic bag, or if your nebulizer is small enough, you can probably use a quart-sized bag, and you pour the liquid into it and put your nebulizers. If you just zip it, you can use a lot less liquid to completely submerge your nebulizers. So this is also a good hack for if you're traveling as well, so you don't have to carry so much stuff around. If you have a pharmacy nearby, you can use isopropyl alcohol or hydrogen peroxide. You just want to remember hydrogen peroxide is for longer. It's for 30 minutes. You can use a diluted bleach solution, which I don't know about you guys, and I really don't recommend bleach because it's really hard to figure out 1 part bleach to 50 parts water. I mean, I can't figure out that math, not in my life. So it just seems a bit too difficult for me. If you're familiar with UV light, so if you go and you get your nails done and they put all the metal pieces under UV light can be effective for cleaning nebulizers. It's a bit expensive. You want to make sure that you look at the manufacturer's specifications because it actually can melt plastics depending upon which one you have. And also when we were looking at sterilizing things like pulmonary function labs for during COVID, we were really worried about that. UV light was very much discouraged because it actually warps plastic over time and you really can't see it properly until it's completely toast. So it is something that is available, but I'm a bit plus minus on the benefits versus sort of the drawbacks. And then one thing that's very popular in the pulmonary community is there's folks will say, well, can I just use vinegar? You know, I use vinegar to clean my house. I use vinegar, you know, to clean my vegetables. Is it enough? And it really has not been proven to be enough in NTM and bacteria like Pseudomonas to completely clear it off of either the structure that it's on, or you know, it's just not potent enough. So we do shy away from asking you to use vinegar, and also vinegar is not regulated to the same, with the same type of vigilance that things like isopropyl alcohol, hydrogen peroxide are. So we don't know if all vinegar is created equal. And obviously not apple cider vinegar or balsamic vinegar, right? We're talking about like pure white vinegar in this case. But we do discourage folks from using that. And then just remember that no matter how you clean or sterilize your nebulizer, you want to make sure that it is completely dry before you use it. Because if you use these methods and then it still remains wet, it is a way that bacteria can potentially get into your nebulizer, and then you don't want to breathe that in. So, and then in terms of cleaning mesh nebulizers, this is the tricky stuff. I have worked with mesh nebulizers for over 20 years and have never gotten great guidance from the manufacturers how we can really, really clean or completely disinfect a mesh nebulizer. So you always want to follow the manufacturer's recommendations. So those little inserts that come in the boxes, and then also they're available online, because I myself have damaged a mesh nebulizer trying to use alcohol or heat steril. I've completely made them toast. And then, like, what good is a nebulizer that doesn't work? So one of the differences that in mesh nebulizers that they recommend in cleaning, which is kind of cool, is they say to empty the nebulizer itself of any liquid that you see that remains in it after your treatment. For 2 to 3 milliliters or cc's of sterile water into the nebulizer cup and nebulize for 1 to 2 minutes. So what you're doing is you're just kind of pushing all the excess, whatever medication was in there, out of the nebulizer, kind of clearing it out. And just like I had said before, all that sterile water is water that's been boiled for 5 minutes. You want to make sure that you store that sterile water in a clean container so that you make sure that it's completely, that itself is sterile. And then you're just going to disassemble all the pieces of your mesh nebulizer and make sure that they properly dry. The actual mesh itself is usually like a metal ring. It kind of sometimes looks like a cone, and it has lots of little grooves in it. So just make sure that you inspect the grooves and that you don't see anything left in it, and make sure that it dries on both sides before putting it back in, because you don't want to put anything back in that you already got out. So there was one question that I saw in the chat before I started that I want to make sure that I address. So we talked about nebulizers and cleaning, and you're breathing in and out through your nebulizers. But when it comes to the different airway clearance devices like Acapellas, Aerobicas, Air Physios, all the different PEP devices that are out there, we worry sometimes as patients and as providers that if you breathe in through the device and then out through the device, and then in through the device again, that if you blew anything out, that you're going to be rebreathing it, right? You don't want to breathe in bacteria that you have gotten out of your lungs. Many centers, including in my own recommendations to patients, when using PEP devices, there really isn't a need to breathe in through the device. There really isn't. Some people choose to combine nebulizer therapy and PEP therapy, and that would be the case in which you'd want to be breathing in through the nebulizer and out through the device. But if you're not using it in conjunction with nebulizers, taking the breath in through your nose has 2 benefits. Actually 3. The first is you're breathing fresh air. You're not rebreathing anything. The second is you're heating and humidifying your air through your nose, your natural heat and humidifier, so that you won't get drying effects of doing lots of repetitive breathing. And the third is that in and of itself, it doesn't provide you any particular benefit to breathe in a PEP as it does to blow out through the PEP. So if you take the breathing cycle of in through your nose, holding your breath, and out through your mouth, then no matter how you clean, sterilize, do anything to your PEP device, you're always taking fresh air in that is not rebreathing anything that you have blown out. if you are using nebulizer therapy in conjunction with your PEP, you just need to really make sure that your devices, whether it's your nebulizer itself and the PEP device itself, are as clean as possible before you start, and then do your therapy and then clean it afterwards, so that you're in your next therapy, you're not re-exposing yourself to anything that you blew out in your first one, because we want the bacteria out. We don't want it coming back in. All right, that is it for me. And I see the Q&A is hopping.
Yes, we have over 100 questions. We are going to try to get to as many as possible. As I said, we are copying all the questions, so we will try to get as many answers as possible, and then we will get to the rest of them and post the answers. Somebody's asking about exercise. They say if you go on a 4.5-hour hike, your lungs feel clear. Will one morning nebulizing or airway clearance be sufficient? In other words, can vigorous exercise be sufficient for airway clearance? This person specifies they have bronchiectasis, but not NTM.
Well, I think I can answer this question. So, awesome. 4.5 hours of hiking. You are a rock star. I don't do that. So if you are doing vigorous exercise and you're taking the time to clear after, that is a great maintenance airway clearance. You just want to make sure that you stay tuned into your body if anything changes. I always caution folks when it comes to airway clearance to not have regular habits, whether it's exercise or nebulizers or doing their PEP devices, because it's really hard to change something all of a sudden when you feel sick, right? So exercise is great. Making sure you're taking deep breaths is great. Making sure you're staying hydrated through that. And using some breathing techniques can be a great form of airway clearance for you. And just make sure that you're checking in with your doctor to make sure that according to how your sputum is looking or how your imaging is looking, that is stable, that is improving with that regimen, and that you don't need to add something to it.
Okay, great. Thank you. I think the next one is probably geared towards Dr. Lozier and Dr. Shepard. Does having COVID worsen the effects of having an MAI infection or having an NTM infection, I guess?
Okay, so I can try to address that one. So having COVID is not a direct relation to MAI or MAC. There's no obviously studies that have looked specifically at whether or not COVID impacts MAC at this point, since COVID is a relatively new thing. But COVID is typically an acute viral infection, and really is the big thing that we're seeing with a lot of the viral infections is that oftentimes we have post-infectious or post-viral bronchiectasis exacerbations that can be secondary to bacterial overgrowth at that time. So it's not just specifically NTM species that we're looking at that time, but whether or not you're colonized with other bacteria, and perhaps it gets aggravated because of increased mucus production and lack of clearance at that time.
Okay. Does everyone with bronchiectasis have NTM? And then this person adds, they've never really understood what NTM is exactly. So maybe an overview of an explanation of specifically what NTM is versus bronchiectasis, and then addressing the overlap of the two diseases.
Shall I take that one? We'll go in turns. No, not everybody with bronchiectasis has NTM infection. Bronchiectasis is a very important risk factor for NTM because of the structural damage to the airways and the pooling of mucus and the inability to clear that mucus, as Ashley and Marjorie have very clearly talked about. But NTM mycobacteria are all around us, and there's always a risk that you may inhale and become colonized or hypercolonized by mycobacteria, but it's not 100%. So there are people with bronchiectasis that don't have bacterial superinfections or mycobacterial infections. And there are people without bronchiectasis that may have NTM, pulmonary infection. So the two go closely together, but not always.
Thank you. Next question, is NTM inherited?
So no, NTM is not generally inherited. It's typically that an individual has predisposed factors for acquiring an infection. Specific risk factors, heritable risk factors such as genetic conditions to acquire bronchiectasis are heritable, but not specifically the NTM infection.
Okay. How often are CTs recommended in caring for a fairly stable patient? What's the risk versus the benefit for doing them more or less often, I guess? And the same question applying for bronchoscopy.
Maybe I'll jump in, and Dr. Loja may be more familiar with the ATM guidelines on this, but and someone who's stable, it depends. Are they on treatment? Are they stable and being watched and not started yet on antibiotics? Have they been healthy up till now? Do they have mild, moderate, or severe structural lung disease, say bronchiectasis versus fibrocavitary disease, which is more severe? All of these factors will individualize our frequency of checking on them, because some people do fine for very long periods of time, and sometimes we can predict that. And sometimes people decline more quickly than that. And so we will want to be much more frequent in our check-ins. And that goes for CT scanning as well. It's often not that helpful to do them very often, because you don't see changes on a CAT scan very quickly, even when the treatment is successful or failing. It takes months, really, to see significant changes on imaging. And so we will stretch it out probably for a minimum of 3 months and potentially longer than that.
Okay, thank you. Somebody's asking, can you please explain the avium part of MAC?
So for Mycobacterium species, there's often the Mycobacterium is the first part of the naming schematic, and then we have this species identification or subspecies identification in each of these settings. So within MAC, it's a complex, and the complex itself is comprised of several different types of Mycobacterium species. So avium is one of the specific species, along with this like intracellulare as another one that's commonly encountered. I don't know if Dr. Shepard, you might have some additional mycobacterial expertise to weigh in on the naming schematics as well.
Actually, avium is bird in Latin. I'm not sure why it's called bird mycobacteria, but I suspect it probably is because it was isolated initially, associated with bird droppings or some sort of bird collected sample. But it is certainly ubiquitous in the environment, so it doesn't, we no longer particularly associate it with birds.
Okay. Are there parts of the world with lower incidence of NTM?
I can kick that one off. Maybe is the short answer. Whenever any incidence or prevalence data is discussed, there's always a big question mark over it because it's highly dependent on how efficiently we do surveillance. And in certain parts of the world, there is not the laboratory capacity nor the healthcare system set up to diagnose NTM. I'm thinking of the global south, places like sub-Saharan Africa, certainly many centers in South Asia or Southeast Asia, South America. So it's a very difficult question to answer. However, one does suspect that it's a widespread environmental organism. So it lives free, it doesn't require a host. And there's no reason why it couldn't live free everywhere on Earth. And the main factor in increasing incidence and prevalence of NTM pulmonary infection is more likely an increase in the number of vulnerable people with the structural lung disease that can become accommodating hosts for this organism, which is everywhere. What do you think, Ashley?
I think that highlights a really important factor is that I think a lot of what we're seeing for increased prevalence and incidence is largely because of increased recognition of this as a condition overall, and testing has largely followed some of that increased recognition. But definitely, I think we're underestimating it worldwide, and a lot of that probably has to do with the availability of testing and laboratory capabilities to be able to monitor for this. Worldwide, as tuberculosis is more of a public health concern, so more labs, specifically with mycobacterial capacities, are likely testing for tuberculosis rather than NTM species. So it's just something that we need to be mindful of, but I think largely there's no reason for it not to be present almost everywhere.
Okay. Does slow growing versus fast growing also refer to how fast they grow in our lungs?
Maybe I'll jump in on another infectious disease type question. Yes. So the slow growers in the lab, for instance, can take a month to grow in culture from a sputum sample, whereas a rapid grower like M. abscessus or chelonae would normally grow within a week of incubation of a sputum sample in culture. So one has to assume that they have those characteristics deep down in a lung, bathed in your mucus secretions as well.
Okay. Next question is sort of a follow-up to the COVID question. Can you quantify and comment on the current information about the risk of COVID and RSV for those with NTM and bronchiectasis, and also advise about prevention, including things such as masking?
So this is an excellent question, really just given the ongoing pandemics and viral season. I think we are very much in the thick of respiratory viral season. So specifically, there are no obvious studies that are specifically looking at risks of bronchiectasis or NTM at large for acquiring different respiratory infections. To extrapolate from that, though, is to look at the risk factors that somebody with bronchiectasis may have. So if you have decreased lung function, or a lot of our bronchiectasis patients may have advanced years, if they're greater than 60, there's an inherent risk for increased risk of RSV. Same for things like influenza and COVID. with greater age, there's typically an increased risk for acquiring respiratory infections. So I think overall, is if we do often suspect that our patients with underlying respiratory conditions may have an increased risk for acquiring other viral respiratory infections, but there is not a direct correlation or studies that look at that at large.
Okay. How does rainfall affect NTM?
Maybe I'll tag team. So there's some interesting epidemiology, at least in the United States, that suggests that increases, as Ashley mentioned, of NTM diagnosis in the southeastern United States. And other studies have highlighted an increase in diagnosis along the coasts, so both east and west coasts. And the hypothesis is that increase in humidity in the air as a result of proximity to the ocean or in an area with high rainfall increases the aerosolization and general floating, I guess, of mycobacterium around us, available to be inhaled. And so that is the causative link that's been hypothesized to explain these observations. So I'm not sure whether it's true. We often see associations on the map, and we need to come up with clever ways to explain why distribution of disease varies with geographical location. But that one sounds reasonable to me.
Okay. For an individual with bronchiectasis, would you not recommend a sauna, Turkish bath, or something similar?
I could take that one. So this is a common questions that I encounter in clinic on a near daily basis surrounding activities like saunas. It's like surrounding questions surrounding showers, pool use, and things like that. A lot of it comes down to ultimately is like your underlying symptom burden at that time, and kind of a lot of what has to do with your comfort levels of balancing your quality of life versus your risk of acquiring potential aerosolized mycobacterium. Oftentimes, is really surrounding the question of pools, even if that is a great form of exercise for you, and that's a way that you can help do some of your airway clearance, then oftentimes that can be a great and effective way to help you clear your airways, and may not always put you at a significantly increased risk of acquiring a mycobacterial infection. But knowing that those environments are prone to having aerosols that may contain mycobacterium, it is just something that you have to be mindful for, as you can then definitely trying to make sure that you're clearing your airways afterwards. So it ultimately comes down to this risk benefit. If something really helps your quality of life factors, then making sure that you're comfortable with that risk, and potentially doing something to potentially help protect yourself if you are putting yourself at any of those experiences where you might have increased risk for acquiring any aerosolized mycobacterium.
Thank you. This one, I'm not sure who should take this, but this is somebody they currently use a Trelegy inhaler once a day. They're asking, is it not recommended since they also have bronchiectasis and MAC? And I think Dr. Lozier, this is probably for you. They're also saying they nebulize with a duo nebulizer, and they're asking, is that okay, or do both of them contain a steroid? I'm not sure you can answer that part without knowing exactly what's in it, but the Trelegy part, I think, should be addressed, certainly.
So I can definitely address that. So Trelegy is a 3-part inhaler. It includes an inhaled corticosteroid, a long-acting muscarinic antagonist, and a long-acting beta agonist. So 3-part inhaler is the part that I alluded to in my initial part of the presentation regarding inhaled corticosteroids. largely depend, and this is a very dependent on what your underlying etiology of treatment is. Certain underlying lung conditions like COPD and asthma respond and need to be treated with inhaled corticosteroids. So if your asthma is progressing or your COPD is progressing and you're having frequent exacerbations, the risk of being on an inhaled corticosteroid often is needed, is like rather than is like worrying about the NTM inherent risks at that time. It's trying to control is like the potential factors that could increase your morbidity or mortality. With regards to the Duoneb, that does not contain an inhaled steroid. It has two other type of short-acting medications in it to try to help with your bronchodilation and essentially help manage symptoms of wheezing and shortness of breath. So that wouldn't be increasing your risk, as sometimes we do have patients use that with their airway clearance as well. But the factor to be mindful of is always kind of questioning if your symptoms are well controlled. It's something to talk about with your primary pulmonologist or primary care doctor is, can you potentially de-escalate your inhalers to decrease your inhaled corticosteroids and potentially start to look at decreasing risk factors, because there are alternative inhalers that do not have steroids in them if your symptoms are well controlled.
Okay. Here's a good airway clearance question for people who don't necessarily have productive coughs, or who aren't necessarily dealing with an active infection. Somebody said they were diagnosed with mild bronchiectasis 2 years ago. They do not have NTM. They do airway clearance with an aerobica. And their question is, should they start nebulizing with 3% saline?
So I think that's a question between you and your provider as to whether that would be helpful for you. You may not be coughing much up because you don't have much to cough up in, generally, but sometimes mucus is just too thick to get up on your own. And that's when things like hypertonic saline are helpful to add moisture to mucus and make it easier to cough up. But when it comes to airway clearance, when folks say, I really don't have mucus, I don't cough stuff up. Like, I know I've been big on analogies today, but I'm going to take you through like a toothbrushing model. Okay. So you brush your teeth every day, hopefully twice a day, and hopefully you have been since you were a kid. And you don't brush your teeth because you have disease in your teeth, right? You're doing it to prevent yourself from, having tooth decay, cavities. And so you've just been doing it forever just to keep your teeth healthy, right? So you know that you have bronchiectasis, you know that there's been some effect to your lungs, and your provider has asked you to do some airway clearance in order to keep your bronchiectasis where it's at, or hopefully improve it, right? And keep you from having infections that you can be predisposed to. So things like a cappella, which is blowing into a device and having that vibration, can help, similar to brushing your teeth, to mobilize things from your lungs, keep your lungs as clean as possible so that you prevent lung infection. Now, whether you need something to help augment that can, with your provider, looking at your imaging, looking at your pulmonary function, they can decide if that would be something that would be helpful in particular to you.
Thank you so much. So we have to wrap up now. We have actually kept our presenters more than half hour past the webinar time. So I would really like to thank everyone for attending. We had a huge crowd. I would like to thank Dr. Lozier, Dr. Shepard, and Ms. Cullinan for presenting to us. This is really one of the most informative webinars we've ever had. Everybody was really thrilled with it. We will be posting the video. We are going to fast track that captioning for you. We will be preserving the remaining Q&A and getting answers to those for you, and we will send that out shortly. Everybody, thank you. This was a wonderful start to 2024 in our programming, and please keep an eye out on your email for information about our upcoming conference in May. Once again, thank you all for attending. Everybody have a wonderful day and a wonderful weekend. Thanks again.